the first of two workshops on integrating sex and gender into cancer research, why and how to advance more equitable practice. The fact that you're all here already says you have an interest in the topic, and some of you may also already be integrating variables regarding sex and gender well into your research. But we hope by the end of this two-part workshop, you'll be able to better operationalize these variables and also consider how best to sometimes consider the integration of sex and gender. A couple of housekeeping notes. Please note that this session is being recorded. The recording will be made publicly available on the George Institute of Global Health's YouTube channel and through other channels. This workshop is in cooperation with, of course, Imperial College, where I'm situated, as well as the Message Project, Medical Science, Sex and Gender Equity, that I hope you'll be interested in learning about because we're having a course starting in February on health research more broadly, not just in cancer, as well as, we're very happy to say, Cancer Research UK. Now, feel free to introduce yourself, who you are, where you're joining from in the chat function, any thoughts about why you're joining, and ensure to keep yourself muted, but you can, if you wish, to keep yourself on video throughout. We'd really like your active engagement. There's going to be opportunities for Q&A. We have almost an hour, in fact, for question period. Keep an eye also on the Zoom because we have a couple of poll questions coming up. So the run of the order here is I'll make a brief introduction, a little bit about why we have this workshop, why we think it's important and timely now. I'll then introduce our two keynote speakers, Dr. Berna Özdemir and Ms. Carolyn Taylor, and then we'll go to the panel discussion. As I said, I'm the visiting professor of global cancer equity in the School of Public Health at Imperial. I'm also the founding chair and co-chair of the Lancet Commission on Women, Power, and Cancer that some of you may have seen in the Lancet in 2023. The first workshop will cover understanding why sex and gender matter in cancer research, with an overview of biological and sociocultural determinants of sex and gender variability in cancer, case studies illustrating the impact across cancer types and research domains, and a discussion including regarding the essential importance of meaningful engagement of people with lived experience, as Ms. Taylor will discuss in some detail. The second workshop, which is February 19th in the same time zone, in the same time frame, is on operationalizing sex and gender responsive cancer research. You'll get practical guidance in this case from Dr. Karina Hockham from the George Institute on study design, data collection, and analysis. In other words, it isn't just about disaggregating data. Policy and funding perspectives, we're happy to have Matthew Tara from Cancer Research UK also on the second workshop, as well as Alison May Berner, who's an expert in gender medicine. We'll discuss pathways for collaboration, training, and dissemination. So without further ado, we're going to have just 3 questions before I give a bit of an introduction to the topic. The first one, and please try to use your Zoom poll to answer these. We want to get good numbers here. How much do you agree with the following statements on a scale of 1 to 5, where 1 is completely disagree and 5 is completely agree? And look for the poll prompt in the Zoom. I'll give you a little more time. I want to make sure as many people who want to answer will answer. We've had about 85% participation. 10 more seconds. Okay. All right. Shall we share the results? Okay. All right. Very good. So everyone can see here out of 64 people, most people were in the second category. Yeah. Okay. And I'm going to trust that you're dealing with the poll because I can see it on my screen. And now we'll go through, yeah. And now we'll go through the second question. Good. How much do you agree with the following I feel confident explaining the different, I know how to account for sex and gender in my research. So for those of you who are in cancer research, or those of you who aren't, I think we have people here from other health professions, other areas of research. How confident are you that you can account for sex and gender in your research? And 1 is completely disagree, and 5 is completely agree. We have about 3/4 of the people that have responded now. All right, last 10 seconds. Yeah, I think this is giving us a good idea of why we have the workshop now. Yeah, thank you. And the third question is free text, and we'd like your ideas of some of the key challenges that you have faced in considering or accounting for sex and gender in your research. So we want to see some free text. I'm hoping this is working. It looks a bit different than on my screen. And if you want to unmute yourself, just let me know if this is working.
Yes, it is. We'll see the results at the end of the poll.
Excellent. Okay, so yeah, have a think about this, because we want to collect data even as we're doing these workshops to get a sense of, well, for the participants, what you identify are the core challenges. We'll come back to that as we go through the question and answer, the discussion, etc. And in the second workshop, as we go through a process to try to help guide each other in operationalizing this. It's easier said than done, isn't it? We're almost at the 1 minute mark, and we only have about 30% participation. So I want to give another 15 seconds or so. It can be one word, it can be a short phrase. Please don't be shy. We still only have about a third. Yeah. All right. Now I can't see people's faces, or the chat at the moment, but we're getting almost 50%. I'd like to see it go up to 50. For those of you who are in cancer research, have you faced any challenges? And they can include, by the way, any kinds of challenges in designing, in analyzing and reporting, or even, dare I say it, to get funding to study sex and gender in your research. Okay, I think we should close the poll in 5 seconds. 4, 3, 2, 1. Thanks so much. Okay. Anna, were you able to share some of the, yeah. Okay, so we'll continue. I wanted gender sensitive medicine. What is it and what is it not? And we thought this was important to mention. I drew actually from a recent article in the ESMO, European Society of Medical Oncology Daily Journal by Dr. Özdemir, where she discusses, an ongoing problem that we're facing, that this is often mislabeled as DEI work, as equity, diversity, and inclusion work, which is arguably related, as is women's health, when we talk about power dynamics and why we're really only now coming to terms with the fact that we have not accounted well enough in the science for sex and gender variations or differences. But that's not what this is. What this is a scientific framework. It's not advocacy. It integrates biological sex and gender-related sociocultural factors into research with the aim of improving cancer the whole ecosystem of cancer, including understanding our risks, et cetera, being able to act on those risks, and of course, equitable cancer care, including the optimal outcomes for everyone, regardless of gender. And the last two slides I'll show also Dr. Özdemir and Dr. Berner, who you'll meet next week, on the next session, February 19th, is that they conducted a survey with over 1,200 cancer researchers and asked them, working in the domain just on cancer biology, what do you think is important? How important is it to account for cell lines, animals, and human samples, to account for sex? And nearly half of the researchers said they didn't know the sex of the cell lines that they use. When it came to cell lines, most thought it was less important than knowing the sex of animals or human specimens. And researchers disagreed that sex differences should be studied in all tumor types. And interestingly, the responses didn't differ by gender of the respondent. Now, we would argue that ignoring sex and gender limits the capacity of precision oncology. Sex actually affects cancer biology, drug metabolism, efficacy, toxicity. You'll hear more about that. Gender, of course, this is not an exhaustive list, affects access, adherence to care, survivorship issues, and on and on. And these can interact as well. And just to give you one very quick example, using colorectal cancer, a cancer that's very common in men and women, almost equally in the risk in men and women, globally, and a major cause of cancer death here in the UK and elsewhere. There's an emerging science that looks at sex as well as gender with respect to non-sex specific cancers like colon cancer. You can see here even interactions with the sex hormones and the gut microbiome. The gut microbiome also differs, it seems, by sex. Take an example of screening. You're more likely to have a right-sided tumor if you have colorectal cancer. You're more likely to have it on the right side, which is a different type of biology, presentation, different thresholds for screening, et cetera, if you're female patient versus a male patient. And then take into account the fact that women are more likely than men to want to wait for a gender concordant provider to perform a colonoscopy if the initial screen was done by FIT, by fecal immunohistochemistry test, for example. And there is emerging data that not only is a sigmoidoscopy not as effective in women as men because of where the scope can go and right-sided tumors being more common in women, but also FIT seems to be less effective in older women. So there's a lot there. I think I've made the case using just that one cancer. And finally, I'd be in big trouble if I didn't remember to mention the SAGER guidelines. We could have asked a question on this, but maybe you could put that in the chat or the Q&A, those of you who want to respond. How many people here know about the SAGER guidelines? Sex and gender reporting, very important. More journals now have adopted them, including The Lancet, of course. But I would say that it's worth noting in our 2023 report of the Lancet Commission on Women, Power, and Cancer, we found that only less than a third of the top 100 cancer research journals in terms of impact factor specifically mentioned sex and gender or the SAGER guidelines in their information to authors section. And that was just in 2023. We think that's improving, so stay tuned for more on that. So without further ado, it's my pleasure to finally introduce Dr. Özdemir, who I'm sure many of you know. Dr. Özdemir received her MD and PhD in cancer biology from the University of Bern and completed postdoctoral training at Harvard University and MD Anderson Cancer Center, University of Texas. She completed clinical training in medical oncology at Lausanne University. Her early research was actually on biology, on genetically engineered mouse models of pancreatic cancer and the contribution of cancer-associated fibroblasts to cancer development and progression. She currently works as a senior physician at Bern University Hospital and a member of the ESMO Gender Medicine Task Force. Her clinical specialties are melanoma and urogenital tumors, and she's investigating sex and gender differences in cancer risk and outcomes with a focus on treatment toxicity. So welcome, Dr. Özdemir. Thank you.
Thank you so much, Ophira, for this nice introduction. It's a big pleasure to be here and having so many participants and also hearing the view of Carolyn. I think we will have a holistic approach and cover a lot of things. So today I would just like to give you an introduction. You nicely set the stage, so I think everybody agrees that it's an important topic. I would like to more cover where do we start and what should we do. Everybody agrees, I think that's a problem, but how should we tackle this? So next one. Yeah, where to start? I think if I would ask now here, the oncologist among you, or even the people living with cancer, what is the biggest unmet need in the era of precision oncology? I think you would find many, many things besides novel drugs and improving outcome of patients. But in my view, one of the main problems we have next is this issue of having really sex and gender sensitive evidence, which leads to precision medicine for everybody. So currently what we are doing precision oncology, but it's not for everyone. It's just only for a very selected group of patients, and it does not consider sex and gender at all. So in the era of precision oncology, I think this is a big, big unmet need. Next one. So as you said in the poll, I think many of you struggle with the definitions. There's a lot of confusion, not only among people not working in the field, but also among, in the literature, among people publishing on this. There's a lot of confusion, and both terms, sex and gender, is used interchangeably. It's often considered more polite to use gender. I will show you that this is not the case, so we must have a correct wording. So when we refer to sex in a paper, sorry, can we go back 1 second? Ophira, yes. So this is essentially a biological variable. So something or somebody, a cell, is either male or female. There are some exceptions. We can have a chromosomal genotype of XXY, Klinefelter syndrome, or X0, the Turner phenotype. But usually this is a binary concept, and this is very much determined on physiological traits such as chromosomes, gonads, and anatomy of somebody. While every cell, animal has a sex, gender is something which applies only to human, only to people. So it's a social construct, man-made if you want, and it's a characteristic spectrum. We cannot consider gender binary anymore. So gender scholars very much push on this, that it is really a spectrum. There are many, many different types of gender identities, and it's something very much controlled or influenced by the roles and stereotypes which are prevalent in a certain culture and in a certain time. It's dynamic. So the zeitgeist is influencing what is considered correct behavior for a man or woman. And this is the WHO in the definition of gender. So a person's self-representation as man or woman or girl or boy, or how he or she is perceived by the society on the basis of their presentation. So that's why when we do research, usually we have the data on sex, on somebody's sex, but the gender identity or how somebody feels or is considering himself, herself, we usually don't have that. So I think in most research projects, it's more correct to talk about sex. Next one. But we must keep in mind that both terms, so sex and gender, are very entangled. So we cannot really differentiate what is influencing the sex or gender factors because everything is in a intricate interplay. So you have already at the level of the fetus epigenetic modifiers coming from the behavior of the mother. And this then leads in puberty when a child is getting the hormonal changes, sees how somebody behaves as a man or as a woman, and learns how to behave appropriately or according to this gender role. Next one. So this means we have in reality such a complex situation, and we artificially disentangle that. At least I do that. I try to do that in my research. Next one. So to have a neat situation where we know these are sex-related factors and these are more gender-related factors. But the whole idea is at the end to generate hypotheses and to be able to go back and see in real life, in the natural situation, what applies. So next one. This is all hypothesis generating, and we must not reduce all these factors to biology, only to sex, but it's easier to investigate. That's where we start usually. So cancer is a prime example of sex and gender differences. On this spectrum, from cancer risk up to cancer outcome, you can see that at all levels, you have both biology-related, sex-related factors that affect a cancer risk and outcome, and also gender-related factors, as Ophira has alluded, such as lifestyle, access, awareness of screening, behavior, and treatment allocation, the interaction between the physician, and so on. So as an example, I will start with sex and gender-related factors of cancer risk. Next one. Next. Yeah, next. Yeah. So we know since the introduction of cancer registries around the 70s that globally, male sex is associated with a greater cancer risk and also poorer survival. And this has been well documented now with a lot of data, and this holds true globally. So independent of ethnicity, genetic background of a person, overall males are at a greater risk. Next one. So historically, how this was explained was mainly with gender-related factors. Next one. So it was assumed that males had more cancer because they had differences in behavior. So they were drinking more alcohol, smoking, and it was also assumed they were doing work in the industry and were exposed more often to carcinogens. Next one. Now we know with the newer research and a better understanding of cancer biology that there are also biology sex-related factors. Behavior alone cannot explain those factors because even if you normalize for those factors, a difference remains. So we know that the immune system of females is more active. It protects you from cancer. The same holds true for sex hormones, especially premenopausal estrogens are very protective. The microbiome, Ophira has said that. This is something also very much related to a person's sex. So hormones influence the gut microbiome, and also importantly, genetic factors. So the X inactivation and in female cells is a mechanism of balancing the gene dosage, but they are among, according to estimations, from 10 to 20% of those genes which are inactivated can escape this inactivation. So if you have a gene which is mutated on the active X chromosome and you have one that escapes this inactivation, you don't get cancer. While in a male with just one X chromosome, this would lead to cancer. And importantly, also, this is for a global perspective, the risk for pathogenic infections is much greater for men. And this is about 10% of cancers are induced by pathogenic infections, bacterial or viral infections. So we have now a better understanding, and we know that both factors play a role, biology as well as gender. Next one. So if you then now look into outcome where we have differences, next. Yeah, I will give you an example. Next one. So we said males have more cancer and they have a lower survival. When it comes to females, the problem is that females have a greater risk of experiencing severe toxicity from all types of cancer treatments. This is also something well documented. There's good data, and this is an example I usually cite, the data from SWOG trials. So this is good clinical data from the US over the last 30 years. About 30,000 patients were included, and you see independently if it's chemotherapy, immunotherapy, or targeted therapies, the risk of developing severe toxicity is in the range of 35 to 50% more for females. And that's highly significant and also very, very relevant clinically. I don't know if how many clinicians we have among you. If you think about the side effects of chemotherapies or immunotherapies, this is not a joke. This is really something you can die of that, right? We don't want to scare patients, but this is really not an academic issue. It is a very clinically relevant problem. And I will show you a patient example. Next one. But before doing that, I would really encourage you to read this great work by Ophira and colleagues, which was published in Lancet a couple of years ago, What we must not forget, again, we are dissecting sex, gender, but there's also the whole situation of a person. We cannot consider a patient, somebody living with cancer in isolation. There's a family around. This person lives somewhere, has a profession, has the whole social context. So this intersectionality of social status, health literacy, financial situation, this all also affects the outcome of a person. And that's very, very relevant. And we see there also that women have a disadvantage globally. That's a big problem. And this is very well depicted in this big work by Ophira. Next one. So coming to our patient case, this is a real patient I treated a couple of years ago. So this patient was coming from a rural area, and she had developed dysuria, so symptoms of, she had to go more frequently to the toilet. So she had also sometimes a bit of pain and had seen that, something was off. And she was going to her family physician, so her general practitioner, and had multiple courses of antibiotics because there was a suspicion of urinary tract infection, which is a common thing in females. But then after about 2-3 months, when it didn't get better with several courses of antibiotics, she finally had an appointment with a urologist who did an endoscopy, look into the bladder with a camera, and diagnosed this invasive bladder cancer. And she was referred to our center. So it was a couple of months after she had all the symptoms that she was finally getting care at the tertiary center. And socially, so this patient was single, no children. She was living with her mother and was working in a bakery. And these are some symptoms of urinary tract infections, but also bladder cancer. Most important, blood in urine. This is always an alarming symptom. Next one, please.
Sorry, I think we're not actually seeing the slides
Really?
anymore. We're just seeing you, Berna.
I adjusted something. Now you're seeing her slides again?
No, just seeing you. We're not seeing the slides.
Okay.
Can see
Not sure.
slides.
Oh, so other people say they can't see the slides, but
I
I
thought
cannot
so.
as a presenter.
Today
Okay.
is challenging with the techniques.
Sorry.
Sorry. Yeah, it's
We'll
been a while
figure
since
out, no
I used
problem.
Zoom as well. So let me go back now. Now I'm not sharing my screen anymore, right?
Yeah, I cannot see anything now.
Yeah. So I need to now go back and share my screen again. Sorry, everyone. Here we are.
It's also a test to see if everybody's checking emails or on social media.
That's
So
right.
you're with us.
Go ahead, please.
Perfect. Next one. Does it move? It's not moving. Yeah, and now. Perfect. It's back. Yes, perfect. So when this patient came, she had staging and she was diagnosed with localized bladder cancer. And in this situation, this is a curative intent setting. You can cure this patient. And what we usually do, a couple of years ago, it was only chemotherapy that was available or recommended. And this is since several decades, a cisplatin gemcitabine combination. And we discussed this with the patient and said, okay, if you get chemotherapy before surgery, you will live longer. It improves your survival. And she said, okay, I will do as you said. As I said, this patient was coming from a very rural setting and quite simple conditions. So she was rather obese, 90 kilos for 168. This gave us a body surface area of over 2 square meters. And as you might know, in oncology, chemotherapies are dosed by body surface area in the idea that this is more accurate than the dosing by just weight. So we started doing that, and after just 2 cycles, meaning after 6 weeks, she had severe complications. So she had a pulmonary embolism, meaning this, and as you can see in this image, a blood clot that was occluding her pulmonary artery. So she couldn't breathe well. She came to the hospital because of that. She had severe dyspnea. And she had also severe infection because her blood values, especially the white blood cells, had gone down. So she had what we call the sepsis. She had to be treated with antibiotics for 2 weeks. Now the problem is, how do we continue with this patient? I think everybody agrees that it's not possible to continue chemotherapy in this setting, too dangerous, so she might also die. And so we needed to do surgery, but she had just started blood diluting drugs, so the anticoagulation, as we call that, to dissolve this clot. So it was also not possible to right away do surgery. So we had to wait a couple of weeks, and then she got her surgery. The bladder was removed. And under the microscope, the pathological examination showed that the tumor had not responded. If you compared it to the CT scan, it was basically unchanged. So in this situation, we discussed with her that she had a high risk of developing metastasis. And we said there's a possibility of getting immunotherapy, what we call adjuvant. That means after surgery, in the intent of reducing the risk of metastasis. And she said, yeah, okay, I will do that. We gave just one shot, just one dose of this drug. It's a fixed dose. IV, and she had what we call a severe hepatitis. So her liver enzymes were very increased. She didn't feel much, but we couldn't continue treatment. And we had to treat her with cortisone for several weeks. And it was very difficult because she was living in a remote area, didn't have transportation. So she had always to ask somebody to drive her. It would take her almost 2 hours to come to Bern. So we had to manage somehow remotely or by phone, telling her, yeah, okay, you can decrease the cortisone, go to your general practitioner, do a blood test. So it was a challenge. But when we also decided we couldn't continue this immunotherapy, we restaged her. Next one. So to check where we were with regard to the disease, which was basically not treated. And she had unfortunately developed metastatic disease, as you can see on the CT scan, the liver with a lot of metastasis, unfortunately. And at that time, because she was exposed to chemotherapy, although insufficiently, and also to immunotherapy, and both were not possible to be continued, contraindicated, the only possibility was this antibody drug conjugate, enfortumab vedotin at that time. And we started this, but it was also very difficult to do a proper treatment, which she should do on day 1, on day 8 and 15. She couldn't do 3 consecutive treatments because she had a skin rash, which is typical for this drug, and also her white blood cells were low. And she had also developed, after a couple of cycles, polyneuropathy, so tingling of the hands and feet. So we had also to interrupt this treatment, and she died only after 13 months after diagnosis. Next one. I think this is really, I show this patient case a lot because it's very impressive how you can get from a curative intent setting, you can still die because you cannot be treated correctly. And some of the reasons for the greater toxicity this patient and others experience are some biological differences. So for instance, we know the body composition between males and females is different. So in a male and female of the same weight and height, you have a difference in lean body mass. This is essentially muscle, and this makes up 80% of the body weight of a male compared to only 65% in a female. So you have more fat tissue in females. You have a different set of sex chromosomes, and also your sex hormone levels are different. And this changes with age. This makes it even more complicated. Next one. Yeah, the second point is pharmacokinetics. So what happens to a drug when you ingest it from the level of absorption in your intestinal tract up to excretion, so clearance of the drug, this is different. So at all levels, there are differences described between males and females. So you can, as a take-home message, usually the same drug given to a female stays longer in the body. The clearance of most drugs is slower for females. There are some exceptions, but this is like a rule of thumb. You can consider that. Next one. And also the pharmacodynamics, meaning what does a drug do in the body, can be different between males and females. So when you get the same drug compared to your brother or your partner or your husband, you will have a different effect. And the dose-response relationship is probably not the same for a female compared to a male. Next one. Exactly, that's the optimal drug dose is probably different between females and males, but so far we don't have this. And one important point is, besides those biological differences, is the data gap, right? Next one. So Ophira has nicely shown the results of this survey. So we already start at the level of drug discovery. So we very much depend on preclinical drug discovery. When we dare ignore differences between cell lines or animal models, you will already start with half of the data. And there's data showing that if you expose a cell line coming from a male tumor or a female tumor, you might get different responses. And it's not because these cell lines are around for decades that this is not true, that they will be similar. So if you think they are not representing tumor biology, then why do you use it, right? So this is a big issue where we must also increase the awareness of cancer researchers. Next one. Then when a drug is identified and it goes into human studies, so usually for pharmacokinetic studies, what is taken as a reference is a male person, 70 kilos usually, and from ethnicity wise, it's a Caucasian person. And all the other patients or people who are going to get this drug are considered as deviations from this standard person. And we usually lack data on female people or obese people or underweight people or different ethnicities. This is often not shown. We did recently a systematic research with the ESMO task force and have seen that really just a very few, for very few drugs, this data was available. Next one. So, and then if we have a drug which is promising and which is then tested, you must know that 80% of drugs are nowadays developed by the pharma industry and the trials are sponsored by pharma industry. You have this balance. So usually you have 60% males and 40% females. There's a recent analysis in JAMA Oncology by Catherine Genet that showed that this didn't change despite all those regulations and the encouragement to increase the representation of females. And it doesn't matter if it's academic trials, they're a little bit better, but most industry trials throughout the world, if it's in Asia or North America or Europe, this ratio stays the same over the last 20 years. Unpublished data from us, we just did a systematic review of neoadjuvant and adjuvant immunotherapies. We see that it even gets worse. There's 70% males and about 30% females. So the trend is not good. With novel therapies, we must really counteract that. Next one. And a big problem is the reporting of clinical trial data. So we have the SAGER guidelines. We should get sex-segregated data from patient characteristics to endpoints, toxicity, whatever. What we get actually right now is only the primary endpoint depicted here as a forest plot by sex. That's the only thing. And because in most registrational trials, toxicity is never a primary endpoint, you usually have a primary end of progression-free survival or response rate or overall survival. You have just this information, but you don't know what to do with it if you have differences. And I will show you an example. Next one. Yeah, I think this shows really to account at all levels, sex and gender. So what to do? Now we explore the problem. I would suggest that we should really urgently explore novel dosing strategies. And let's start with chemotherapies. What can we do there better? Next one. Yeah, next. As I said, the traditional body surface area-based chemotherapy dosing is very, very inaccurate. We know that since years, but so far we couldn't find a better way. So it means that if you have a male and female person with the same weight and height, you will get the same dose. Independent of your sex, age, or body composition. You might be obese, 80 years old, or 50 years old. Theoretically, you should get the same dose. Next one. Yeah, and as I told you already, this cannot be correct because your body composition is completely different. So meaning in this example, next one, the lean body mass, which is the most important parameter and one of the most, accurate metrics of measuring drug clearance or predicting drug clearance is this lean body mass, essentially muscle mass. There you have a difference of 10 kilos. If you just take the weight and give the same dose, you will not consider that the female patient has 10 kilo less muscle mass, so she will have a clearance much slower the drug exposure will be longer, and that's why she will develop more toxicities or severe toxicities. And importantly, again, it's not just about sex. This is one of the factors. The age is also very important. You have a decline in lean body mass with age. In females, this starts with menopause. You lose a lot of muscle mass, and it seems intuitively clear that a person of 80 years should not get the same dose as somebody who's 50. In clinical practice, we usually adapt based on experience, but if you are a resident starting, you will just do the calculated dose, right? You want to do it correctly. You want to be a good doctor, and you say, okay, this is what I calculated, and I'm exact. And you usually also give the 10 milligrams. You don't round up. Next one. So what is a novel way how we could dose these chemotherapies is based on the lean body mass. On this picture, you can see how the body composition can be analyzed. They are computer programs. If you have a CT scan at the level of the L3, so the lumbar vertebra L3, you can measure this. The red one is the lean body mass, and this correlates very well with the rest of your body. And we have already talked about that and published how this could be done. And there was a recent, next one. Yeah, we could replace this body surface area based dosing with the lean body mass dosing. It correlates better with the volume of distribution of chemotherapies, and it's a better predictor, as I said, of drug clearance than other parameters such as body surface area, BMI, and so on. And I'm very pleased to say that there was a recent French study, a phase 2 trial in colorectal cancer, where they did dose according to lean body mass, one of the drugs, and you could see that there was much less toxicity, significantly less toxicity without impaired survival. Next one. This is the Lenox trial, an academic trial. I think we need confirmation in larger trials, but this is very encouraging and shows that this is really feasible. We just must do this. Next one. Yeah. And in the example of the patient, so I told you she got this drug, antibody drug conjugate, enfortumab vedotin. This is something approved for bladder cancer in pre-treated patients. And in this analysis, you can see that the percentage of female patients was about 20% who got this drug compared to about 80% males who were treated. And if you can next. Yeah, if you then look into this forest plot, so this is the primary endpoint in this analysis. This was survival, so it's about death. You see that this drug seems to work very well in males. The hazard ratio is 0.61, corresponding to a reduction of the risk of death of 39%. In the females, however, you see that this point and the whiskers, they cross 1, and the hazard ratio is 1.17, meaning that you have an increase of 17% in the risk of death. The confidence interval is 0.72 up to 1.89. So we don't know if this result is correct. The range of confidence, it could be that there's a reduction of risk of 28%, but also an increase of risk of death of 89%. That's how to interpret that. And this is a big, big data gap. We don't know what to do with this data. The argument that comes if we say, okay, does this drug work less in females, is no, you cannot deduce that because the trial was not designed, not powered with the intention to show this or to answer that question. But you feel slightly uncomfortable asking or recommending this treatment to your patients. But it's also not ethical to withhold this treatment, which is an approved treatment, based on a subgroup analysis which was not powered. So you see the difficulty in clinical practice. We must urgently close this data gap. And I'm discussing this all the time with people, key opinion leaders who design trials and so on. It's not an afterthought. If you say, okay, we will then do an analysis by sex just to get the second paper out. It's not about that. You must design those trials from the beginning correctly. This is our duty to the patients, right? Next one. Yeah, so here is an approved treatment, and there's nothing, no mention of this potential. It's not discussed anywhere. It's just shown because this journal wants you to show the data, but that's all. Okay, and this is really poor. So one last point. so Ophira said that this is not about just women. And also in this article, I really emphasize it's not about fixing the problem for the women. This comes like that because mostly females are in disadvantage. Often this data gap affects women, but it can affect men too. So this is the example of bone loss, osteoporosis. You see also men get osteoporosis. This is more rapid with the menopause in females. Next one. But if you look into the population of people, this is data from an Italian clinic, yeah, the number of men who consult because of the osteoporosis is smaller compared to the number of females. But if you look into the reasons why they come to the clinic with bone loss, next one, this is usually secondary osteoporosis, meaning that this is something related to a treatment or another disease, such as diabetes or treatment with cortisone or treatment for prostate cancer, right? Everybody who treats breast cancer patients, the patients and their physicians know that this is increasing their risk of osteoporosis. I treat a lot of patients with prostate cancer, but a couple of years ago, we never touched this topic. We never mentioned osteoprotective therapies with these men. And they are usually older when they get prostate cancer, and they can also die from a hip fracture, right? So we must increase the awareness, and this is not, gender medicine is not about women's health only. It affects everybody. It is the basis of offering precision medicine to everybody. Next one. Yeah, with this, I would like to just summarize what we discussed now. Where are the barriers to really get to this sex and gender-based evidence medicine, precision medicine? There you see that the drug dosing is extremely imprecise. It is not taking into account the body composition, the differences in pharmacokinetics or pharmacodynamics. So you have a greater toxicity in women, well documented, independent of the drug type. And plus, you have those structural barriers in clinical trial, how this is performed. So the trials are designed and powered not to assess any differences in drug effects, but they must be if you want to reach this evidence-based medicine for everybody. We must really power them to look into potential differences. We must report data. Sex segregated, we must allow data sharing. In theory, data sharing is there, but nobody can access those clinical trial data, although a lot of patients committed, gave their time and had a lot of, I think this is patient-owned data. But nowadays, it's very inconvenient for the companies to share data. And also we must increase awareness among all the stakeholders, starting from the cancer researchers, industry, regulatory bodies, funding agencies, and also in the community, patients, patient advocates. They must demand that this is taken seriously. Next one. Yeah, with this, I hope I could show you where to start. So I think this must be our common goal of everybody working in the field of cancer, that we want to reach precision oncology for everybody by taking into account sex and gender. This is not a niche. This is not just for interested parties. This is for everybody. And what we need to do is explore novel dosing strategies. We have AI. We could use this to measure the body composition. We must also understand the biology behind those sex differences, not to remain descriptive, right? So we know what's happening, how are hormone pathways playing a role, and we must urgently close this sex and gender data gap in clinical practice so that we have guidelines where I'm comfortable proposing a treatment to a patient and recommending because there's evidence. Yeah, with this, I would like to close. Thank you very much for your attention and looking forward to the discussion.
Thank you so much, Dr. Özdemir. That was a masterclass. Every time I hear you speak, I learn so much more. Really appreciate it.
Thank you very much, Odile.
Thank you. I'm sure there are many questions. I can't see the chat at the moment, but we're going to have plenty of time. I think we'll have Ms. Taylor's keynote next, and then we should have about 40 minutes for a good discussion. So thank you very much indeed. So I have the good fortune, the pleasure of introducing Carolyn Taylor, who's the founder and executive director of Global Focus on Cancer, and she works globally at the intersection of people-centered cancer care, policy, and health system reform. Her work integrates the lived experience and psychosocial perspectives into research and decision-making processes that shape cancer systems. She collaborates widely, including with the World Health Organization, the City Cancer Challenge, academic institutions, civil society partners, and she contributes to multiple Lancet commissions focused on people-centered systems. And I have to add that she also chairs the Patient Advocacy Committee for our Lancet Commission on Women, Power, and Cancer. Ms. Taylor, the floor is yours. Thank you.
Thank you so much, Ophira, and thank you, Dr. Özdemir, for what an incredible presentation. So my presentation really bridges workshops 1 and 2, with my focus being on the meaningful engagement of people with lived experience in cancer research and how we move from principle to framework to practice, particularly in work that aims to be sex and gender responsive. I think I would be very remiss if I didn't acknowledge that while my work is global, I live in the United States, where sex and gender research and evidence that exposes inequity are increasingly being challenged, constrained, and sidelined. So this work is even more urgent than ever. This isn't about engagement in the abstract, this presentation, but how lived experience becomes structured, accountable, and influential within research and system change. This is particularly important in sex and gender responsive work, where power and equity often shape whose experiences count as evidence. Next slide, please. So this work draws on 15 years of practice through Global Focus on Cancer, working with communities, researchers, clinicians, policymakers, really across diverse health systems. And across these contexts, one lesson has been consistent. Cancer systems work best when people who have experienced cancer are not just consulted, but they are meaningfully engaged with real influence, moving past what has been the tradition of symbolic inclusion. Next slide, please. So my presentation is structured really around 3 stages. First, the principle, what is meaningful engagement and why lived experience matters. Then the framework, how that principle becomes a global standard. And third, the practice, what meaningful engagement looks like when it's embedded, structured, and accountable. And this arc really matters because engagement often stalls at principle without the structures that are needed to make equity possible in practice or to shift power in truly meaningful ways. Next slide. Lived experience provides essential evidence. It's the context, the nuance, and system realities that quantitative data alone doesn't always show us. And this is really important where sex and gender shape access, burden, and decision-making. And when you include people with lived experience in research, it strengthens the relevance of research or program design. It improves the feasibility and acceptability of interventions. Psychosocial, communication, and care experience dimensions are more fully realized, and it helps build trust, credibility, and accountability across cancer research, policy, and care systems. This is not anecdotal information. It is experiential evidence. It is evidence that helps us understand how systems function in practice, not just how they are designed on paper. Next slide. When we talk about people with lived experience, we mean individuals who have personally navigated cancer, whether that be through their own diagnosis, treatment, and survivorship, or through caregiving. I intentionally avoid the word patient because lived experience, as Berna just recently said, is broader than clinical identity, right? It includes the psychosocial, economic, cultural, and systemic realities that are often shaped by sex and gender. So when you're including people with lived experience in research, it helps surface gendered barriers that are tied to the social determinants. Things like transportation, stigma, workplace discrimination, family obligations. We know these factors often determine whether care is accessed, sustained, or abandoned, yet they are fairly invisible in many formal systems. Lived experience shows us how systems function in real life, and that insight is essential for designing research programs and policies that meet the people's actual needs. Next slide. Here I'd like to talk about moving beyond the idea of a single patient voice towards lived experience as expertise that operates across the entire research to policy continuum, from shaping questions and methods to informing policy and system design. This is where the power shift happens. That is really what this is all about. That shift is critical, especially in gender and sex and gender responsive work, where key drivers of inequity sit outside formal data sets. When people with lived experience are meaningfully engaged, power moves from being consulted at the margins to shaping the questions, the decisions, and the priorities. In sex and gender responsive work, this shift is truly essential because many of the barriers people face never appear in clinical or administrative data unless lived experience has a pathway to influence. Next slide. And despite the growing recognition of this importance of lived experience, engagement across cancer systems is still often rhetorical rather than practical. We see the language of engagement, a voice invited at the end, a one-off consultation, maybe an advisory role, but there's not real influence. There's very little accountability for how input shapes decisions or what impact it is actually having. So when we move from rhetoric to practice, we require some sort of structure, right? So it means involving people with lived experience from the beginning, not after priorities have already been set. It means removing barriers through compensation, support, and accessible processes. And it means sharing influence in ways that genuinely affect research, design, interpretation, and policy decisions. This is what turns lived experience from a gesture into evidence and from participation into real impact. Next slide, please. And this is where the global standard comes in. The WHO framework on meaningful engagement is the first formal UN guidance to define what meaningful engagement actually requires. And it was co-created with more than 700 people with lived experience, governments, researchers, and civil society. Its foundation is influence and power. Engagement is meaningful only when people with lived experience can help shape priorities, decisions, and outcomes, not just contribute perspective. The framework is grounded in 4 values: dignity and respect, recognizing lived experience as expertise; equity, where we're removing financial, social, and structural barriers to participation; compassion, creating safe and supportive environments; and accountability, showing how lived experience changed decisions, design, or policy. And together, these values move engagement from tokenism to co-creation. They provide more or less a blueprint for embedding lived experience across research, policy, and systems work. Next slide, please. So, and I'd like to share a case example of how we're applying these principles in practice. And this is GRACE, the Gender Responsive Analysis for Cancer Equity. It's a 7-year multi-country research and implementation initiative being implemented in Tbilisi, Georgia, Nairobi, Kenya, and Leon, Mexico. It's led by City Cancer Challenge with support from Global Focus on Cancer. The goal is to strengthen cancer care for women in low and middle income settings by understanding how sex and gender shapes access, experience, and outcomes. And then working together with the local teams to co-create solutions that make systems more equitable and accessible. GRACE works across 3 pillars: generating local data on gendered barriers through evidence and capacity, developing a gender responsive healthcare workforce, and access, improving services and informing policy. But what really sets GRACE apart is that lived experience is embedded structurally. Each site includes a person with lived experience as a full research partner, shaping tools, identifying barriers that data may miss, and co-interpreting findings. GRACE doesn't just study inequities, it models a way of conducting research that shares influence and power and centers those most affected within the research process itself. Next slide, please. In GRACE, the WHO framework is translated into 5 core practices. Inclusion, people with lived experience are embedded as full members of the research team. Partnership, engagement is continuous across design, implementation, and interpretation. This is not just a one-time consultation. Support is made possible through participation, or participation is made possible through support. It's valued through orientation, plain language materials, fair compensation. And then to be very transparent in what we're doing with clear expectations, roles, and pathways for influence that are well-defined. And then we document, we have documentation mechanisms that capture where lived experience, where that input shaped the work, making engagement not just visible, but also traceable. And this positions engagement as a standard practice rather than an aspiration. But it still remains flexible enough that it can be adapted across diverse settings. Next slide, please. So engagement in grace really follows an infinity loop, meaning that it's continuous and it's reciprocal. People with lived experience contribute by refining tools, identifying barriers, bringing cultural insights, interpreting findings, co-presenting results. Research teams are responsible for creating these enabling conditions that support engagement, including psychological safety, orientation, accessible materials, compensation, and clear opportunities for influence. And this ongoing exchange keeps engagement active and influential. It supports a shift from participation towards shared leadership in the research process. Next, please. And our approach is grounded in global best practices, because there are things that out there that exist that we can base measurement on. So from the WHO Meaningful Engagement Framework, we draw the core values of dignity, equity, compassion, and accountability. From the Canadian Institute of Health, the strategy for patient-oriented research, we take the domains that define high-quality engagement, inclusiveness, support, mutual respect, and co-building. And then the GRIP 2, Guidance for Reporting Involvement of Patients and the Public, gives us a practical reporting structure. It's the foundation for our GRIP 2 light log. And PCORI, the Patient-Centered Outcome Research Institute, and the National Institutes for Health and Care Research offer guidance on fair compensation, authorship, and recognition. And together, these frameworks provide rigor and alignment with global standards while allowing for contextual flexibility. Next, please. In GRACE, engagement is both a value and a measurable practice. And this is reflected across 5 dimensions: inclusiveness, support, mutual respect, co-creation, and accountability. The first tool shown here is our GRACE engagement rubric. It's aligned with WHO and the CIHR guidance. It's important to be clear that this is not an audit or a performance scorecard. It's a structured reflection tool that helps teams assess how engagement is being practiced across these dimensions. Teams complete the rubric at 3 time points: after onboarding, after data collection, and prior to dissemination. And this helps reflect on where engagement has been strong, where additional support might have been needed, and where power is genuinely being shared. The goal is learning and improvement, moving deliberately away from tokenism into co-creation. Next slide, please. If the rubric helps us assess how well engagement is being practiced, the GRIP 2 light log shows where and how it influenced decisions. And this tool is adapted from BMJ's GRIP 2 reporting framework and is used to document really concrete examples of lived experience input. What was raised, what changed, why that change mattered. We just put in examples here because the study is ongoing. But you can add in anything that's relative, adding questions on indirect costs, identifying gaps in psychosocial and navigation services, or shaping intervention design to reflect the realities of rural women, as Berna was saying before, or also in her example. This isn't about claiming casual impact. It's about transparency. It's about accountability. It's being able to show that lived experience did not sit at the margins, but informed the research design, the interpretation, and policy relevant outputs as well. And together, the rubric and the GRIP 2 light log are really, they're simple but effective tools that help make meaningful engagement visible, traceable, and credible. Next slide, please. And these measurements, they shouldn't be thought of as bureaucracy. It's really about trust building. And it shows where lived experience helps strengthen design, data, and interpretation rather than just assuming it did, because that is often the case. In GRACE, each site co-defines the indicators with their lived experience partner, so measurement reflects the reality and not just merely a checklist. Those insights feed into shared learning across sites and into a GRACE engagement metric focused on influence, not just participation. And this is how we make engagement visible, credible, and accountable over time. Next, please. And these principles sit underneath GRACE, but they are not GRACE specific. They underpin meaningful engagement in gender-responsive research and health systems more broadly. Language matters. The words we choose, patient, survivor, beneficiary, they shape identity, power, and whose knowledge is seen as legitimate. People-centered language is not semantic, it's structural. Individuals do not exist in isolation. They are embedded in families, in communities, in workplaces, and social roles. They are all shaped by sex and gender and all affecting access, experience, and outcomes. Participation is not a courtesy. Engagement must create real pathways to influence decisions that affect people's lives. Evidence matters, but evidence that doesn't inform policy, system, or practice change risks reinforcing inequity rather than addressing it. This is something that I deeply consider as a person with lived experience before I engage in a research project. And finally, system transformation. At its core, meaningful engagement is about shifting power towards equity, towards justice, and shared ownership of health systems. This is a lot of the work that we're looking at in the New Lancet Commission on People-Centered Care for UHC. But together, these principles really translate power into practice, shaping how engagement is designed, resourced, and evaluated. Next slide, please. And this slide captures the shift from power to practice. Why engagement matters is straightforward, right? It strengthens cancer systems by making real-world barriers visible, the ones that rarely appear in clinical or administrative data. And when engagement is embedded, it builds trust and system relevance. But meaningful engagement doesn't happen by accident. It requires deliberate choices. Language that recognizes lived experience as expertise, participation with real influence on decisions, evidence designed to inform policy, and a conscious shift of power towards those most affected. In practice, this means engaging people early, co-creating rather than consulting, resourcing engagement appropriately, using accessible tools, sharing power and authorship, and being able to show what actually changed. That's how we move engagement from intention to impact. Next slide, please. Meaningful engagement is more than a technique at its core. It's really about designing research and care with people, not for them. It's a mindset and a method and an accountability mechanism. It strengthens research and system design by grounding our work in real lives, real barriers, and real needs, particularly those shaped by sex, gender, power, and social context. For sex and gender responsive research, engagement is not optional. It should not be optional. It is how inequities become visible, how assumptions are challenged, and how evidence becomes fit for purpose. If we want cancer systems that are more just, more humane, and more responsive, then engagement must be embedded from the beginning with structure and shared power. The question is no longer whether lived experience has value. It's whether our research and policy systems are structured to integrate it as expertise with influence, accountability, and impact. And with that, I say thank you. We can go to the last slide, please.
Thank you so much, Ms. Taylor. I'm going to switch now to first names for everyone. Carolyn, that was beautiful. What a brilliant talk. I always learn so much from you. I'm sure there's so much here to unpack, and we're going to now transition to the panel discussion. I'm going to see if I can show meeting without stop sharing and see if that works, just to show everybody's faces. This is new for me. I haven't been using Zoom much. So I think that's the way to do it, right? Do you all see your faces now? No? Okay, I'll stop
You
sharing.
still see, yeah, now it's good.
Yeah.
All right. That's okay. I'm learning. You think I'd know by now. Well, wonderful. Now I can see more people as well. I'm sure there's a lot of questions. People have introduced themselves in the chat. You can continue to do that. I'm going to scroll back a bit and start looking through that. But in the meantime, I'm going to take the moderator's privilege and ask the first couple of questions. So I'm going to start with you, Carolyn, with everything that you've just said, from principle to framework to practice. If the audience here takes away one key thing, the audience who includes cancer researchers and also funders and I think publishers, how to move from rhetoric to real accountable engagement and people with lived experience and sex and gender responsive research. Do you have a key message? Do you have one or two pearls you can share with us? Thank you.
Yeah, I think, what's really important for me is to say that shifting this engagement shouldn't be an invitation, but a responsibility, right? It shouldn't be this nice thing to have, but really it should just be included all the time. Um, I've been invited to projects late, after questions were framed, after decisions were already effectively made, to add, the lived experience perspective. And when that happens, like me, it's not meaningful. It's instrumental, right? So I have chosen to step away from that work. I really think about it, and you don't just get to have the lived experience stamp without meaningful engagement. I think it's a two-way street too, that people with lived experience also need to be considerate in how they engage as well, not just putting the rubber stamp on, but actually demanding it as well, being an advocate in that space. So I think it's bidirectional, but I do think it should just be a constant in work at this point.
Thanks. It's like a continuous variable. We all need to keep learning. Berna, you've been doing this work for a long time now, and I guess at this point, at this particular juncture, as Carolyn alluded to, with the political climate and the reversal of many or efforts to reverse the rights of girls and women, which I know is not the core topic here today, but just in some jurisdictions, even the word gender is so fraught. Do you feel that things are better now in general in terms of incorporating sex and gender variables, or even having these discussions about the science around sex and gender in your research? Do you think things are better now than when you started, or is there still a long way to go? I know you did the survey, but yeah.
Yeah, I think for sure there are 2 points. I think among the scientific community, there's more awareness and more interest for sure. When we started 2018, this work, it was rather something people considered, on the side. It's okay, it's interesting, but it's not real the hot topic. But now they see this is really foundation of precision medicine. I think by saying that like 10 times a day, it now gets recognized as something important. And we are now doing this European cost action to really integrate sex as a biological variable more into cancer research. This is an initiative led by Ivana Jaric from the University of Zurich. I'm there in work package 5. I'm co-leading the immunology oncology part. There's a huge interest across Europe from many countries. So I think the research has got that. With regard to the political climate, I think this is something artificial, and I'm very upset about how things turned. I think it will be reverted because it's artificial, it's against the human nature. But how, some people consider saying gender, and they put you in a certain place and say, okay, you are doing advocacy work and so on. It's not about that. This is a scientific problem, and we must really place this. This is not about being political. And in my feeling, this is also something which has been considered or pushed against to really revert from more urgent problems like the climate problem and all the other political problems we have. So this cannot be the solution to, because it's not a secure topic, to not work on that until the climate gets better. We must continue doing our work. I think we are always seeing our patients, people with lived experience. We owe that to them. And what politicians think about that is, I think, is very much subject to change because they are not going to live forever.
I guess that's an interesting way to put it. I do see that there's so you can there's an actual Q&A. I've only seen a few questions pop up so far, but please do open the Q&A and feel free to write your questions there, or if for some reason you can't find it, use the meeting chat. Otherwise, it was mostly, there's some good sharings in there. I note that Alice Witt from the Message program at the George Institute highlighted the work of the Message and the Message course that's coming up. So please keep an eye out. And Matt, I might call on you in a moment because you're obviously very much involved in putting on this workshop series with us from Cancer Research UK. And you've also noted something about CRUK's work with meaningful engagement. In fact, if you want to unmute and share that verbally, and I see you have a question as well, you're most welcome to.
Thanks, Ophira, and thanks, Carolyn and Berna, for some fantastic talks too. No, it was just to kind of acknowledge, obviously, that for us in the UK and the kind of research community that we sit central to, that how we refer to it as patient and public involvement is an indispensable part of good research. And I'm cheered and encouraged by the fact that we as a funder sort of take that extremely seriously. I think it helps being a publicly funded charity that we have that connection with people, and there's obviously a sense of accountability that goes with that beyond the research itself and being kind of community facing as the default. I've kind of overloaded the Q&A with a couple of questions, so feel free to take others. But my question to Berna was around my interest around sort of intersex patients. I know you kind of looked at male and female as perhaps kind of the predominant focus for how biology might play out, or at least where we can get reliable data. So I'm curious about that. And then also, it was in reference to Carolyn's point about measurement isn't about bureaucracy, that I fully uphold as well. But I'm curious as to how she's managed to convince the more resistant members of the research community who are very reticent to do anything different. Speaking of, on the behalf of someone leading on work relating to things like inclusion and research. But yeah, I'd be happy to hear from both of you when you have a thought.
Thanks, Matt. So we'll take those questions one by one, and I know there's other questions also. I just want to make a comment that although Dr. Alison May Berner is not available today, she will be giving a talk specifically regarding gender diverse populations and her work with the trans community in the second workshop before we launch into the how-to part, the operationalizing of this work. Berna, do you want to respond to Matt's question?
Yeah, I think Matthew said already, it's clear we lack completely data, and we have a very limited knowledge about all the interplay of chromosomes and hormones in intersex. That's particularly interesting. They are animal models, these 4-core model. I don't know if you're familiar with that. There's some insights where you can play around a little bit with, with this SRY region of the chromosome, which is the sex determining region. You can delete that and at the same time see if you can do ovariectomy or remove the testicles in animals. For humans, data is lacking. I think Alison is doing great work with transgender cancer patients. And I just want to point out, this was related to the question by Stephanie Archer. I don't know if I'm pronouncing this correctly. It's clear we are already, when we discuss this topic, this is just one part of it. And in the lay community or in society, people always, when we talk about gender medicine, they have the expectations that we are going to talk about trans people. But I must say, so people understanding trans people's biology or the issues around that are very limited. So we don't have this expertise. And this is just one part of the gender medicine. So we must really place this in a good way, that it's not taken really as this topic is about intersex or transgender people. This is part of the precision medicine, and we must really owe that also to the trans patients to really understand their social gender-related needs, but also the biology.
Thank you for that. And I'm just going to add one little comment before we go to Carolyn's response. I'm involved in a community that includes maybe a couple of people here on the call. I haven't been able to see the whole list. Participants called Common Sense Oncology. And the common sense part is absolutely valid. We need to bring back humanity into cancer care and research, but it has to do a lot with data and the way that we design and analyze and report, especially clinical trials and clinical research. But interestingly, it's been a little bit more of a challenge, in my view, to convince the community of people within this CSO group that sex and gender is sort of hiding in plain sight as something that we should also address. So I'm saying that here live and for the recording, hoping to convince them that this should be included. Carolyn, do you want to address Matt's other comment, and then we'll go to the Q&As that are remaining in the box. Thanks.
Yep, sure. So yeah, Matt, thank you for that question. And I think research, more and more research grants, right, are requiring someone with lived experience to be in the research study. But I think by creating tools to measure, like giving them instruments so it feels more robust, is really beneficial and really helpful because then they see it as real data, right? So, and I think providing an orientation as well to the value of what this is and how engagement should be done, because not everyone knows. And it really, as I was saying, it works on both ends. Like people with lived experience also really need to be oriented well to this because you shouldn't just be happy to be at the table, right? Um, and it's this meaningful engagement, not perfunctory engagement that I think is really the value there. And providing tools and frameworks is what's really critical.
Thanks so much. I think there's probably much more for us to discuss in that regard and perhaps in the second workshop as well. I also note that Korean Hakum is with us. And Karina, we're really lucky to have you on the second workshop to get us to the how-to part, as you're doing so much of this work in health research in general, and you'll draw some from some cancer examples. I might come to you in a moment on the panel, even though I didn't tell you that in advance. Haha. Now I see there's a question from Mark. Is it Skopak? Did you want to ask that verbally, or do you want me to just read it?
There's a bit of noise in the background here, so if you could just read it, that'd be easier. But thanks.
Sure. So thanking us for the presentations and saying, as Dr. Özdemir demonstrated, there's a gap and unmet need that disproportionately affects women or people of female sex. Is advocacy necessary to address and right that imbalance? And does framing this as just, in quotes, a scientific framework perpetuate the status quo? I love this question. If I can try to answer it myself first. Yes. Advocacy is also needed. It's important to note that what we're presenting today is the science, and that's why we wanted to make sure people understood this is about the best science to advance the best outcomes in terms of cancer risk, the prevention and care, right? Throughout the continuum, et cetera, people living with and beyond a diagnosis of cancer. But advocacy is very much needed, especially now, as others have said. And that's one reason why we framed our Lancet Commission. First of all, it wasn't sex and gender in cancer. It was about women and power being central to that, the power dynamics. In that report, for those of you who haven't seen, published in 2023 with some follow-up work since then, including some metrics and a framework to monitor progress at that intersection of power dynamics and cancer, also published in the Lancet in 2025. We talked about why this is the case, why we're in 2026 now, only starting to come to terms with some of these differences that have not yet been incorporated into clinical practice guidelines, let alone a lot of the research. And a lot of that does have to do with who is asking the questions and on what basis are we prioritizing the questions. So advocacy is needed. Do either of you, Berna or Carolyn, also want to chime in on that one?
I think you just said it, and I would just like to emphasize that diversity is extremely important in this research. Although I'm very happy that female leadership is here, this field was developed by female scholars, and is also, as Ophira mentioned, the questions we ask are different. There's a publication showing that over 1 million papers, that if the first or last author is a female name, the chance of this paper looking into sex and gender aspects is significantly higher. So it seems a topic that women address, but we urgently must get men doing this research, more diversity, that it doesn't stay a topic where women try to fix a women's issue, right? That's what I would like to emphasize. And of course, we are passionate about that topic, and advocacy goes with that.
Thank you. And stay tuned also for some research I happen to be involved in with my colleague, also formerly at the U.S. National Cancer Institute, Elise Garton. We have worked with the International Cancer Research Partnership that includes CRUK and NCI and others from this community. And we looked at the PI, the gender of the principal investigators on like all of the research in most of the participating organizations. And it's not good. So we can take a look at that, as well as authorship, as some of the metrics that are surrogates for how we can do better. I see a question by Jacqueline Valverde Villegas from the Sanger Institute. Like to listen to your thoughts about which key aspects we need to think about when performing the consent form. When working with pregnancy tissues or cell lines as they come from a susceptible group or a vulnerable group. Thanks for organizing this. That's an interesting question. Berna, do you want to take a a shot at that? I might come to Karina for this, actually. Go ahead.
Yeah, I think this is really interesting because there's also an FDA guidance which wants, especially after the pandemic, to include pregnant women into research, so clinical trials. And so far, we have always been very reluctant to include pregnant women to protect, obviously, the unborn child. I think this is something we need more guidance on that, honestly. When pregnancy tissue or tissue, after delivery is taken, it is routine to perform tests on that and so on. And people even can select to freeze some of the stem cells. But I don't know if the consent is really addressing this and how long this tissue is going to stay stored and so on. That's a great point. I wouldn't know how to address this topic. Also,
And
people need to be involved. I think we need to involve patients into this discussion.
absolutely. Sounds like an interesting question for my colleagues at the George Institute, which work on a lot of issues regarding pregnancy and healthcare research. Karina, did you have anything to add to this? Thank you.
No, I was going to say the same thing as Berna. We need more guidance on this, and within the Message Project, we are exploring an extension of that into Message Maternity, working with obstetricians, gynecologists, and members of the public to better understand how pregnant women and women who are lactating can be better included in clinical research. But then also, as Carolyn outlined beautifully, having women who that this effect would be really important in that consultation. And whilst we wait for that, including those members of the community in ongoing studies is also going to be really important.
Great. Maybe this will come up also next week as we talk about some solutions and ideas for how to improve on all aspects, also from the research funder side, which we'll hear much more from Matt. I'm just going to draw now on Jackie Marshall's comment and question. The sex and gender inclusion case is clearly very strong as research approaches the clinical world. How far back down the research pipeline would you like to see these considerations go? It's a good question, assuming the data problem were addressed. Who wants to try to address that?
I think from my perspective, it's surely when we discuss drug discovery, if we are using living organisms, we must consider that at that level. A lot of that is going to be probably now in silico by AI. I think many companies are seeing the potential of AI, discussing the protein structure and so on. It can predict much more than what we can do in a wet lab. But I think there's enough data to suggest if we are using cell line derived from female or males and animal experiments, of course, we must consider at that point. Very important, you are going to discuss this next week, but it's not that you are going to need the double number of animals or the double number of experiments to show that. So don't be afraid to check with a statistician to really have proper data to look into potential differences. You are better off than thinking of that afterwards and trying to figure out how to get back in case a reviewer asks. So that would be my advice.
Excellent. And definitely stay tuned for, it's not next week, but on February 19th, we're going to have more about this. I see a couple of good questions for Carolyn. I'm just going to jump one ahead because it comes back to the animal studies, et cetera, from Anne. Sorry if I'm saying people's last names wrongly. So Kimball Hill. Recently, NIH has pushed towards organoids and away from animal-based studies. How can we make sure that sex and gender is still included in future study development in this context?
I think it's the same as with cell lines. So this was very fancy organoid research a couple of years ago, but I think it doesn't solve all the problems. It is still artificial. If we look into a perspective of tumor microenvironment and so on, it doesn't cover all that. But for sure, we must consider organoids coming from a female or male person. And also, if it's supposed to be individualized treatments, then for sure, this is just data valid for one patient, like the patient-derived xenografts and so on, which we were using a couple of years ago.
Thank you. And just coming back to the question about how far back down the pipeline we should go, if this hasn't been mentioned yet, I forgot when I showed that slide with all the colorectal research, sex and gender interactions, et cetera, I forgot to mention that there's a recent not a systematic review, there's a recent analysis of an already published clinical trial. So this is something also that's very possible to look at the original data sets and then, as in the case of this recent paper in JNCI just a few months ago, I'm sorry, I forget the name of the first author. It was a phase 3 RCT of, I think it was the addition of an anti-inflammatory, perhaps to an existing chemotherapy regimen. And there were no differences between those, but then they looked by sex and gender in terms of, in fact, in terms of sex with outcomes, including toxicities. And that was yet another example with another clinical trial showing the same thing that we've seen before. But I'm sure there's other ways to look at retrospective data. Yuki, you had a good question about people with lived experience for Carolyn. There's 2 questions for Carolyn, so I'm going to try to blend these. One is, although it may not be specific to sex and gender in cancer research, how can we improve? I think it's about inclusion. People with lived experience, how do we help bring them into? Funders ask us to include costs to support this work, but it competes with costs associated with or considered so-called core research costs. So we're never able to have the time and resources that this work truly needs, meaning well-intentioned engagement work risks becoming tokenistic. How can we improve this? And should we be encouraging funders to ring-fence engagement costs or require that these costs should make up a certain proportion of the overall costs of a research grant? Great question. Carolyn?
Yeah, I mean, it should just be included as a core component of the research. It's often, I always say, I don't have protected time at all, right? So I'm always asked to do things without being funded, and like we have to start saying no. But I think it's really reframing. This isn't like a discretionary activity. It really needs to be thought of as a methodological requirement. And in that framing, as you're writing a research proposal, you need to include it from the beginning, not rely on someone else to fund it. You need to include it in your funding. It has to be, and maybe the indirects go down a tiny bit to cover that. I think academic institutions, yeah, I know Ophira's hysterically laughing at that one, but
just coming from the NIH, that's a whole other thing. Yeah.
Yeah, I know. But also, like when we have partnered on research grants, like Global Focus on Cancer with academic institutions, often we end up doing the bulk of the burden of the work and we get the least money. So it's quite challenging in that respect. So I think that it just has to be reframed. As you're writing a research grant, that has to be put in from the very beginning. I think that is, and again, putting that budget in, but funders should be asking also, like, what is the value of lived experience and how does it change the input of the study and what are the outcomes? And again, as I alluded to before too, it's thinking more of, not just in terms of what papers are we going to publish out of this, but what policy are we going to influence? And I think that's where bringing lived experience in becomes so much more important because of advocating for policy change and things like that. So it can actually make your study a much more robust and rigorous study in terms of policy. So framing it that way can be really beneficial, I think.
Great, thank you. And Matt, did you want to say anything about that or you save that for next week? I think just being here a short time in the UK, just 4 months so far, I see a lot more of really intentional, inclusive, I hope meaningful engagement is baked into a lot of the research that I'm seeing here on the public health side. But that's I don't know if that reflects the reality in the UK more than where I've been in the past or what.
Yeah, absolutely. I mean, as I said earlier, I think it's a core element to the research we expect. I think where it's a bit more challenging, which my colleague Jackie alluded to earlier, is sort of earlier on in the pipeline trying to encourage more basic scientists that perhaps have kind of got their head down, focus on a microscope or in a data set and start to think of kind of the real human impacts and relevance there. So there are kind of efforts to see where it's most meaningful, as Carolyn was saying, so that it actually is impactful rather than tokenistic. I'm not sure I can speak though at length about costs and how to change that.
Fair enough. There was, I think, one other question, but maybe you've already covered it from Ninian, is it? Since we're focusing on gender and sex, do you have any specific thoughts on how meaningful engagement should be aware of gender and sex? You touched on that, of course, in your
I
talk.
mean, a little bit. It's, when we think, I think like, we think about biology and treatment response and side effects, and gender shapes us access and decision making, continuity of care, and that engagement of people with experience, moving that into this work really helps surface where those intersect and where we can standard data isn't enough, right? And so I think particularly incorporating that lens into your research, like thinking about framing the research questions, interpreting the findings in that lens is really beneficial. Yeah, I
Right.
hope that answered that.
Yeah, absolutely. I don't see any other unanswered questions right now, but I just want to ask you, ask Berna. I had one other question for you. Yeah, if you could go back in time, ha ha ha. I sometimes think of this. What would you say to your 20-year-old self? No, I'm kidding. But what would you say to your early career self? Are there aspects, if you could share, you don't have to, in your own research that you have done in the biology, in the lab? I mean, you did a lot of basic science earlier on, and now you're a clinical researcher that you wish you had known, or that might have made a difference. I mean, you gave us some really salient people experiencing cancer being treated by you. So I think, according to Carolyn, I can use the word patient. We've been talking
No,
about
they
that.
were her patients. If they're an active treatment, it's fine.
Okay.
Yeah, I'm sorry,
Doctor,
I'm not a native
it's just
English speaker, so
contextualizing it.
we use the word patient. It's not meant to be, hurting anybody. We say patient
No.
with cancer or cancer patients. So I think you know my commitment to that. But I think it is has a different feeling if you talk about people with lived experience. I think it sounds much nicer. It's not intentionally if we omit that. So just a disclaimer. So I think if I would go back and could do something differently, I have to say, for my career at least, I'm quite happy that it turned out like that, because I got into that topic by doing exactly what I was doing. So I was very much interested at that time in immuno-oncology and targeted therapies, molecular tumor boards. That was very fancy, like 10 years ago. And we were trying to find out the one patient who had a molecular alteration to provide this patient a drug. So I was part of this molecular tumor board. And there by searching for data, I first realized that there are so many differences if you look based on genetic background. So, an Asian person with an Asian background or African American background does not have the same risk, and so on. So we worked a little bit on that. We published a review on this topic. And then the most obvious question that came to my mind is, we are looking for genetic alterations, but the most important difference, so those two chromosomes, XX, XY, is not considered at all. So we are claiming to do precision medicine, but something very basic, which is there for free. So we know the sex of all patients basically is not considered. And I thought that was very important. And actually, when I started working on that, I realized there's already some data out there. It's just not considered. It's just taken as a sideline, something, okay, interested in case you want to publish another paper, but who cares in this line? And so I'm very happy how my work brought me here. I think it has been great. And we reached some progress. I think we made great progress, but it's slow, but we must continue. And I think the community is very, dedicated, and we have great advocates such as Carolyn doing great work, and the awareness is getting better and better.
Thanks. And I also note that ESMO, ASCO, and other major cancer societies are trying harder to engage on the side of the health professions advancement, which is a parallel issue and speaks a bit to the advocacy, but it's not the same thing. And when I sometimes mention women and cancer or sex and gender and cancer, people think that's what we're talking about, like your article alluded to. So for those of you in the audience here and who are participating in the workshops, it would be helpful if you can share with us, if you've experienced that, or if you as we go forward in the next workshop, to think about how we can all be part of the solution to convince each other that this matters, it's important, and actually has real outcomes for real people with cancer. I think probably we should wrap up and go to just repeating 2 of the poll questions. And I'm going to ask Anna if she'd like to show those on the screen without, or I guess you can just do the poll part, so I don't have to share my screen again. Good. So we'll do the poll question. Number 1, how much do you agree with the following on a scale of 1 to 5? I feel confident explaining the difference between sex and gender. 1 is not at all. 5 is completely agree. Let's give that a shot.
So it starts by 1. On top is 1 or 5.
Oh,
That would be bad. So
no,
after
well, you and
talking
I,
2 hours, you still cannot explain the difference.
you and I are co-hosts, so we might see the screen differently. I think
Okay.
if they see the screen with the actual poll to complete, with 1, 2, 3, 4, 5, 1 being completely disagree, 5 is completely agree. Yeah. This is why you need an AV team. I do. I'm so sorry. All right. We'll go for 1 more, 10 more seconds. We've got almost 48 participants, but that includes a few of us. So up to you, Anna. You think we should end the poll? We have 3/4 of participants. Okay, what do we see at the end? Can you share the results?
Yeah, they're displaying now.
Well, I still don't see the numbers either. Do you guys see the results? I'm a co-host.
I don't see it.
No. You guys see it and we don't. Okay, well, this is what I'm learning of running a Zoom meeting of this caliber.
So we've got just 4s and 5s, which is great. So 42% on 4 and 58% on 5.
That's wonderful. Thank
Okay.
you so much. Apologies, I can't see it. Great. And let's do the second question and then we'll wrap up. The second question is about, being able to account for sex and gender in your research. So obviously, people who might not be researchers might not answer. So 1 is completely disagree, 5 is completely agree. I know how to account for sex and gender in my research. I'll give it another 30 seconds or so. And Anna, I will ask you to end it when you think it's best, and then please say the results out loud. Thanks. We'll obviously keep track of all this. There's a lot of work to be done, and we're trying to plan potentially a series. This is helpful information for us.
Can you see that, Ophira?
No, what do we have?
So we have 7% on number 2, so somewhat disagree. 21% on number 3, 59% on 4, and 14% on 5 completely agree.
14. So we'll look later and see if that improved, but it probably did. I couldn't see it before. I don't know if you can go back and show us. Okay, and the third question was on challenges, the word cloud, which we've kept, which is fantastic. I just want to ask if there's anyone else who had a burning question or issue. We still have a couple of minutes. I won't name him, but I know there's some senior publisher / editor-in-chief on the call. If he or she would like to make a comment, he or she are most welcome to unmute if they're still on the call. Okay, I'm going to take that as a no. That's all right. Okay, so I'm going to ask to stay tuned, please, for the second installment. This is going to be an excellent session where we have Matt, who you now know, we have Alison May Berner speaking about gender medicine and that really important issue about people who identify as trans who are in the cancer health system or not, and why that is and how to help engage, and also to have Karina, who's going to do a great service to all of us by showing us some of the how. I'm just going to share that one slide. Operationalizing practical guidance on study design, data collection analysis, integration along all the domains of cancer research, policy and funding perspectives from Cancer Research UK, and discussing a pathway for collaboration. I'm hoping also this will generate some interest in the course, in the message course, which is on health research more broadly, not just cancer. Please note in the chat, Alice Witt had put something in there. You can also look up message, just print it out, medicine, message, sex and gender, and you'll see an opportunity to sign up for that course. That course does have a cost, but I'm telling you, it's going to be worth it. And Karina is very involved in that and will give us a little summary of it in the next workshop, February 19th. Thank you so much to everyone for joining today. We really appreciate everyone's input, and we look forward to learning more from all of you as you share your challenges and solutions. Thanks so much, everyone.
Thank you very much. Have a nice day.
Thanks.